Hello folks, I welcome you all to this new session in which we will discuss about congenital glaucoma. Hi, I'm Dr. Rashmi Malhotra and I'm assistant professor in DMC Ludhiana. So as per classification, it can be either primary congenital glaucoma, that is, which occurs due to dysplasia of the anterior chamber angle. It is generally present at birth or within first few years of life. Then it can be secondary infantile glaucoma, which is associated with inflammatory or neoplastic causes or hematomatous or metabolic abnormalities. And there can be juvenile glaucoma that occurs after the age of 3 years or in early childhood. There is another way to define childhood glaucoma, that is true congenital glaucoma, which is present at the birth or during intrauterine period, infantile glaucoma that occurs up to the age of 3 years, and juvenile glaucoma that occur after 3 years and up to the age of 35 years of age. That is called juvenile glaucoma. So basically, childhood glaucoma can be either primary or secondary. Primary is because of angle anomalies without ocular and systemic abnormalities, which is also known as true primary congenital glaucoma that occurs within the age of from birth to 3 years of age. Then there are primary glaucomas in which angle anomaly is associated with ocular and systemic abnormalities, under which there can be juvenile open angle glaucoma that occurs between 3 years up to early childhood. There can be different kind of ocular abnormalities like Axenfeld's anomaly, Reiger's anomaly, Peters anomaly, iris ectropin syndrome or others. And plus there can be systemic abnormalities like chromosomal disorders, connective tissue disorders, metabolic diseases and others. Then there can be secondary causes, that is associated with non-acquired systemic diseases or syndromes or ocular anomalies like Loeys syndrome, rubella, phacomatoses, aniridia, persistent hyperplastic primary vitreous. And sometimes secondary glaucoma can also be associated with acquired conditions like intraocular inflammation, infection, neoplasm, trauma, lens-induced, steroid-induced, angle closure or neovascular. And then under secondary, we also consider those glaucomas that occur following cataract surgery. So here we will primarily discuss about primary congenital glaucoma, which is a developmental abnormality of angle of anterior chamber leading to high intraocular pressure. So now if we talk about prevalence, 90% of the cases of primary congenital glaucoma are sporadic in origin. Only 10% have autosomal recessive pattern, and mostly the loci have been found on 2p21 chromosome, 1p36 and 14q24 chromosome. 60% are diagnosed by the age of 6 months and 80% are diagnosed within first year of life. The overall prevalence is 1 in 10,000 births. 70% are bilateral but asymmetrical. Boys are affected slightly more than girls. Chance of having second sibling with the same disease is 3% and chance of having third sibling having the same disease is 25%. So let's talk about Barkan's membrane. In 1955, Barkan assumed that there is a thin imperforate membrane covering the interior chamber angle in the eyes, in the infant eyes, which prevent the egress of aqueous humor and leads to increased intraocular pressure. This was subsequently championed by Wurst in 1966, but the light microscopy and electron microscopy has not conclusively found any membrane in any of the specimens. There is widespread anterior segment anomaly, that is abnormal insertion of ciliary muscles, and sometimes it is also associated with other ocular abnormalities. So in toto, the faulty development of angle of anterior chamber from neural crest derived cells, that is trabeculodysgenesis, leads to absence of angle recess, flat or concave iris insertion, which leads to impaired aqueous outflow, and this leads to elevated IOP. So the infants show very different symptoms as compared to adult patients with glaucoma. The main important symptoms are epiphora, photophobia and blepharospasm. This triad is very important. Always remember epiphora, photophobia, and blepharospasm. There may be corneal signs like edema and enlargement, and there may be hyperstria, which are vertical tears of descemet membrane. Another important sign is ophthalmos, which means eyes just like that of buffalo. Basically, there is enlargement of the globe as a result of elevated IOP. All segments of the outer eye, especially the cornea and sclera, expand principally at the corneoscleral junction. The anatomical landmarks are displaced and anterior chamber becomes deeper. Hence, the sclera shows thinning. There is visualization of underlying uveal tissue that gives a bluish hue. The anterior chamber becomes deeper. The iris shows iridonesis and atrophic patches in the later stages, and less because of the stretching of zonules causes lens to flatten and may even subluxate. And then because of the enlargement of the globe, there may be axial myopia, and which may lead to anisometric amblyopia because of the asymmetric presentation of the congenital glaucoma. And then there may be raised IOP, there may be increased cupping of the optic disc, and eventually, if not treated in time, it may lead to glaucomatous optic atrophy, leading to loss of vision. All the infants with congenital glaucoma suspects should undergo examination under anesthesia. It is mandatory in all the cases. Under GA with ketamine, patient is taken because all other lead to decrease in IOP. So first of all, what we do, we measure the IOP either with Perkins or tonopen. Then we measure the corneal diameter, which tells us about the ophthalmos. And then we do ophthalmoscopy and gonioscopic examination. On gonioscopic examination, in a normal infant, iris root is visible. Prominent ciliary body band can be seen along with trabeculum. But in a case of congenital glaucoma patients, iris roots are present, but ciliary band is not visible due to translucent amorphous tissue that obscures the trabeculum. Okay, so the ciliary body band is not visible. Okay, the differential diagnoses are hazy or cloudy cornea, that is the mnemonic of which is stumped, that is sclerocornea, trauma, ulcer, metabolic disorders, Peters anomaly, and endothelial dystrophies. Then it has to be differentiated from other causes of lacrimation like congenital nasolacrimal duct obstruction, keratitis, and conjunctivitis. Then it has to be differentiated from other causes of optic cupping, that is dyscoloboma, hypoplasia, physiological cupping. And we also have to rule out other causes of corneal enlargement, that is megalocornea and high myopia. Then Descemet's breaks can also be found in forceps delivery or birth trauma. In forceps delivery, generally the Descemet's breaks that are seen are generally horizontal, whereas in this case the harp stria are generally vertical in orientation. Always remember, medications are not very effective in congenital glaucoma. The role of medical management is temporary only until the surgery is taken up. All we can give is hyperosmotic agents, carbonic anhydrase inhibitors, and beta blockers. Miotics and alpha-2 agonists are not used in children. Alpha-2 agonists are also contraindicated because they can cross blood-brain barrier. The primary surgical options are goniotomy, trabeculotomy, trabeculectomy, combined trabeculectomy with trabeculotomy, and glaucoma drainage devices. So goniotomy is one of the most common procedures done in congenital glaucomas. Here patient is taken under general anesthesia and under direct visualization under direct gonioscope, that is copious gonioscope. An incision is given at the level of trabecular meshock with Kahu blade uh, up to Schlem's canal to increase the outflow of the aqueous humor. The procedure is considered to be successful if there is 20 to 30% decrease in the IOP post procedure. Always remember, goniotomy can only be done if the cornea is clear. If the cornea is edematous, angles cannot be visualized. So in such situations, trabeculotomy is the surgery of choice. What is done is that the canal of Schlem's is exposed at about 12 o'clock position by a vertical scleral incision after making a conjunctival flap and a partial thickness scleral flap. Then the inferior prong of the hams trabeculotome is passed along the Schlem's canal on one side and the upper prong is used as a guide. Then the trabeculotome is rotated so as to break the inner wall over 1/4 of the canal. This then is repeated on the other side. The main difficulty of this operation is to visualize, to localize and identify Schlem's canal. Generally, the change of orientation of the fiber is a sign that we have localized or we have reached the Schlem's canal. And if everything fails, trabeculectomy or the filtration surgery can be performed, in which a new channel or fistula is created around the margin of a scleral flap through which aqueous flows from anterior chamber into the subconjunctival space. First, a superficial scleral flap is created. Then, after dissection of the scleral flap, and a deep sclerotomy is created through which we enter the anterior chamber, through which we cut a small piece of iris, creating a peripheral iridotomy, and then we suture that flap. This creates a small partial thickness fistula through which the egress of aqueous humor occurs in order to control the pressure in anterior chamber. So to summarize, management of a case of congenital glaucoma suspect, child should always be taken under examination under anesthesia for corneal diameter measurement, tonometry, gonioscopy, ophthalmoscopy, and slit lamp examination. Once the diagnosis had been established, patient should immediately be taken for surgical procedure. There is hardly any room for medical therapy. It can be taken only until the patient is being taken up for surgery. So the procedures that can be possible are goniotomy, trabeculotomy, trabeculectomy, or combined trabeculotomy with trabeculectomy. So if the procedure is successful, patient should be kept on closer follow-up. If it is unsuccessful, then filtration surgery with antifibrotic drugs, glaucoma drainage devices, or cyclodestructive procedures may be required. I hope you learned something about congenital glaucoma today. In next session, we will discuss about secondary glaucomas. Thank you.